Okay, good morning, everyone. Let's go ahead and get started with Grand Rounds. And it's my pleasure to introduce our visiting professor today, Dr. Stephen Katz, on behalf of Dr. Del Chiaro and myself, Marco Del Chiaro. So just a bit of background. Dr. Katz grew up in Brooklyn, New York, attended Wesleyan for college. He then went to NYU for medical school. And I think we were talking about this last night. During medical school, Dr. Katz wanted to become a cardiologist. And then one of his family members developed cancer. So he then became more familiar with what goes on with cancer patients and how cancer doctors treat cancer patients. So he decided to change his trajectory and go into a career in surgical oncology. And he was looking around for research jobs, and there's this small little place called Memorial Sloan Kettering in New York City, right down the street from him. And he contacted the surgical department and came across one of the sarcoma surgeons by the name of Johnny Lewis. And Johnny Lewis at that time was working on the gene gun. And I still don't quite understand what it is, but it sounds good. And I believe that's when you went to his lab for that summer and probably a couple of summers and became very involved in the research at Memorial Sloan Kettering using genetic techniques to attack cancer, using immunotherapy, which was just on the horizon at that time. And then he completed residency and then went for a formal surgical oncology fellowship at Memorial Sloan Kettering and finished that, kept up with his immunotherapy and did a lot of the work, and then went to the Roger Williams Cancer Center where he became very involved with CAR T cells and using immunotherapy and augmenting CAR T cells. And he has done really a lot of work in that field, has become one of the nation's most prominent surgeon scientists in immunotherapy. And a couple of years ago, made a major career decision to, yes, keep operating, but to limit that to a day a week plus clinic, but to spend the majority of his time with a company called TriSalus. He is based in Rhode Island, and they actually have an office here in Denver. And so he's goes back and forth a lot. I think you're in Denver, 6 times a year or so? And we have the CEO also of TriSalus, Mary Sella, who's a guest with us this morning. And when I look at Dr. Steve Katz, I see a surgeon scientist of the highest order, still practicing and taking care of sarcoma, melanoma patients, but really pushing the boundaries in terms of CAR T cell therapies and immunotherapy and just taking care of our cancer patients. And with that, I'll have him come up to the podium and give us a tour of what's going on in immunotherapy and CAR T cell therapy. So thank you and congratulations.
Thanks.
Let me get my coffee.
Thanks for the generous introduction. Good morning. It's great to be here. I thought I would start by explaining why this is of interest to people that are surgeons. Immunotherapy has already become an integral part of cancer care. It's really transformed certain diseases, melanoma, lung cancer, and others. But it's a little early to do a victory lap because we haven't made a lot of progress in patients with liver tumors. Now, as a surgeon, you may be asking yourself, why do I need to know about immunotherapy? Well, if you're going to be involved with cancer patients in any way, it's likely in the future that your patients will receive some form of immunotherapy. The other interesting thing that we've seen happen, particularly in cutaneous melanoma, is that as immunotherapy becomes more effective, drugs like checkpoint inhibitors, nivolumab and pembrolizumab, we see more of a chronic disease setting where patients are alive longer with tumors, and some of these lesions, even metastatic lesions, are going to be resected. And so the role of the surgeon in the care of these patients is going to evolve and change. And so understanding how immunotherapy works, what some of the adverse events are, and how to monitor response to immunotherapy, I think is going to be critical for a surgeon. And the other thing we're going to see is that immunotherapy is going to be used more and more in the neoadjuvant setting. So you're going to be operating on patients who have received immunotherapy. So again, understanding the mechanisms, the side effects, and the kinetics of response and how to measure response is going to be so important in making clinical decisions for these patients. But today we're going to focus on liver tumors. And as I mentioned, immunotherapy has had some great success in melanoma, lung cancer, CAR T cells with leukemia and lymphoma. But we really have not done a lot for patients with primary metastatic liver cancer. And we're going to explore some of the reasons for that. Much of my research in the lab has focused on the immune system in the liver and how it's so unique and how it's able to shut down our endogenous immune responses so that we can't fight the malignancy on our own. And it's also, unfortunately, able to shut down the patient's ability to respond to immunotherapy, whether it's a checkpoint inhibitor or cell therapy. And the very unique biologic features of the liver, in my opinion, need to be carefully considered in developing novel therapeutic approaches to help these patients benefit from these advances. And here are my disclosures. And so here are the learning objectives. We're going to talk about how to identify and study novel mechanisms of immunosuppression within the liver. And we want to think about this from the vantage point of what can we do about it? Are there druggable targets? Is there actionable intelligence that we can use to develop novel therapeutics? 2, to analyze existing data on liver immune cell biology to understand how the liver TME is unique, and to evaluate delivery approaches. One thing we overlook all too often in oncology is, are we getting enough drug into the tumor? And I'll share some information with you that will raise important questions about how we can do this better. Here are my objectives for my career. I thought I'd share them with you. These have been driving me for close to 20 years now, and I don't see that stopping anytime soon. I've always wanted to understand the specific reasons for immunotherapy failure in liver and pancreas tumor patients. Why are these patients so resistant? I think at a very basic level, we need to understand this to develop more effective approaches. And ultimately, what I want to do is transform liver tumor patient outcomes through focused translational and clinical development of novel immunotherapeutic approaches. So that's what I'm focused on doing, and that's where I've tried to put all my research. And so here's the outline for the talk. We'll begin with a little bit of background on immunotherapy, then a little bit of data on liver immune cell biology, and again, why the liver is so unique immunologically and why we have to think about it in a very different, tailored way, and then the progress we've made with immunotherapy. And then, of course, the barriers. So like so many wonderful things in this world, this probably all began with a surgeon. So on the Upper East Side of Manhattan, at the end of the 19th century, Dr. William Coley noticed that a patient with an unresectable neck sarcoma, and you're seeing the patient here, developed an infection postoperatively, likely erysipelas from a streptococcal strain. And what Dr. Coley noted was that the tumor spontaneously regressed over the course of several days. And Dr. Coley actually found this patient on the Lower East Side of Manhattan months and years later, and the tumor had not come back. So Dr. Coley hypothesized that something about this infection led to the tumor regressing. Now, Dr. Coley didn't know what a T cell was, didn't know what an antibody was, there were no checkpoint inhibitors and so on. But just making that link was a seminal observation that eventually, 100 years later or more, led to the growth and emergence of immunotherapy in this country. Now, this was called Coley's toxins. I'm sure some of you have heard that term, and it wasn't a flattering term. It was meant to capture the idea that when Dr. Coley tried to replicate this, and he created mixtures of bacteria and injected them into patients, most of these patients got very sick, and some of them died. And so they were called Coley's toxins, and really nobody believed that this would ever work. It took a long time for the science to catch up, but it has. And so immunotherapy is no longer a toxin. It's deeply integrated into and meshed within multidisciplinary cancer care because now we understand what Dr. Coley was doing. Dr. Coley was essentially injecting toll-like receptor agonists into patients and stimulating dendritic cells and macrophages and getting T cells to come into the tumor and destroy the malignant cells. And now we have a much better handle on how to do this in a controlled fashion, and that's a lot of what we're going to talk about today. And so I think a lot of people consider immunotherapy to be the fourth pillar of multidisciplinary cancer care alongside surgery, chemotherapy, and radiation. So a bit of a refresher on immunology, just so everybody understands what we're talking about. So what we would like to see in every patient is that tumors release antigens, and then these antigens or foreign proteins are recognized by antigen-presenting cells, dendritic cells or B cells, that then chop them up into little pieces and then present them or show them to T cells. And that's how you develop a T cell response, whether it's to your COVID vaccine or to a tumor. That's what you would like to happen every single time. And one of the most important and remarkable things about immunotherapy is its durability, in contrast to other forms of cancer therapy. For example, the response rates to FOLFIRINOX in stage 4 locally advanced pancreatic adenocarcinoma are quite high, but the durability is very low. This is one of the biggest and most important differences when it comes to immunotherapy. There are patients who can respond and actually maintain that response or even be cured, and that's what we call the tail of the curve. If you look at the Kaplan-Meier curves in the checkpoint studies for melanoma, you see that the curve flattens out and it stops dropping. You really don't see that with other forms of cancer therapy. Why does this happen? Because of memory T cells and memory B cells. I'm sure all of you remember that from medical school, where immune systems actually develop an amnestic response that can quickly come back to the scene and attack the cancer when it comes back. But it's not a perfect world, and what often happens in cancer patients, particularly within the liver, is that tumors, cancer cells can hijack various regulatory mechanisms that our immune systems have. So we don't want our immune systems going unchecked. So we have molecules like PD-1 that naturally exist to slow down or stop the immune response when we no longer need it. That's a good thing. The bad news is that cancer cells are very smart and diabolic, and they can exploit these pathways to shut our T cells down. And so this is the problem within the liver, is that these mechanisms of suppression, particularly myeloid suppressor cells, as I'll spend quite a bit of time talking about today, really leave patients unable to respond to immunotherapy. And if we don't address that specifically with what's wrong in the liver, I would argue that we're not going to help most patients with primary metastatic liver cancer using immunotherapy. So a little bit more background. What is a checkpoint inhibitor? I just briefly mentioned it. It's a regulatory mechanism to shut down or slow down T cells. So for example, if we develop an immune response to the flu, we feel sick because the T cells are making cytokines, but we want that to stop at some point. And so this is what checkpoint molecules do for us. But tumor cells express ligands for these checkpoint molecules, and this essentially slams the brakes on the immune response. What checkpoint inhibitors do, and this is the simplest analogy I've heard, and this is from Jeff Weber, one of the leaders in the field, is that checkpoint inhibitors cut the brake line. So the T cells can wake up, become reinvigorated, and actually respond to the cancer. And that's why they've been so successful. The other form of immunotherapy that I'm going to focus on today is cell therapy. And this is where I've spent a lot of my time as a researcher and a clinical trialist. And cell therapy, in a very simple way, is really just trying to recapitulate an immune response, or in the case of CAR T cells, manufacture an immune response. So for example, when you give a patient a vaccine, to COVID or a cancer vaccine, you're hoping to induce an immune response. You're hoping the patient is stimulated to generate an immune response to the target protein or antigen. With CAR T cells, you're actually just taking a shortcut. And so you're taking white blood cells out of a patient, you're genetically modifying or reprogramming the cells, and then giving them back to the patient. And you're modifying them in a way where they can recognize and destroy cancer. So you're basically manufacturing the immune response that you would otherwise hope to generate, and then just giving it to the patient. Unfortunately, in the liver, this only works some of the time because the immune system in the liver shuts it all down. And that's what we're going to focus quite a bit of our time on. So to summarize what I've covered so far, immunotherapy is already integrated into standard oncology care, and I think it's very important for surgeons to understand immunotherapy because your patients will be receiving it. The role of neoadjuvant immunotherapy is going to increase markedly over time, and the role of surgeons in resecting resistant metastatic lesions, I think, is also going to increase over time, and so understanding this is going to be important. Checkpoint inhibitors and cell therapy have succeeded in certain diseases, but there has been minimal or negligible impact on patients with primary or metastatic liver tumors. And we need to know why, and we need to understand the biology so we can develop better solutions. And so the next thing we'll cover is immune cell biology in the liver. So this is, I think, a beautiful picture from our lab showing a CAR T cell killing a tumor cell. So we made a CAR T cell specific for KIT, which, as you all know, is a protein expressed and involved in the pathogenesis of gastrointestinal stromal tumor. And this is a target cancer cell. And CD3, which is a marker for T cells, is in red. And the green protein on the cancer cell is caspase-3, which is a marker of apoptosis or cell death. So if you could just get these two to come together, you can kill cancer. And this is kind of what happens with leukemia and lymphoma, where the malignant cells are circulating or in lymph nodes. And that's why CAR T cell therapy has been so successful in ALL and various B-cell lymphomas. But this is not what happens in the liver, because in general, CAR T cells don't have a fighting chance because immunosuppression in the liver shuts them down, and so they're unable to do this. And strategically, this is how I think about attacking liver cancer using immunotherapy. It's broadening the thinking to understand that we're not simply trying to kill cancer cells. That is simply not enough. We all want to do that. It would be great if we can do that in a very straightforward fashion, but it's not straightforward. Not only do we need something that can kill cancer cells, like a CAR T cell or like a chemotherapeutic, but we need to treat the disease as a whole. And I would argue that the disease includes the tumor cells, the dysfunctional immune microenvironment in the liver, and there are biologic delivery barriers, which I'll address a bit later. And if we don't address all of these issues, then the majority of patients won't respond to immunotherapy, and we won't be able to leverage the success of checkpoint inhibitors and CAR T cells in these patient populations. So we need to think about the disease as a whole. We need to think about disease biology broadly if we're going to succeed in these patient populations. Another way I like to look at it is this. So take, for example, a stage 4 colorectal cancer patient with liver and lung metastases. Traditionally, I think we all think about this as one disease in two locations. So if we give the patient a drug that's effective for the disease, then they have a chance of responding. I would argue that this is actually two different disease processes in two locations, because it's not just about the tumor histology. When you think about cancer, it's a very complex biologic process. It's a dialogue between tumor cells and immune cells and stromal cells. And the immune cells are very different in the lung and in the liver. The stromal cells are very different. And so if we don't think about how tumor cells are impacted by their environment, particularly with immunotherapy, where I think this is most relevant, we're going to have a very hard time treating these patients with checkpoint inhibitors and CAR T cells. And the liver, as I have mentioned, is very problematic in this respect. At baseline, the liver is a very tolerogenic or immunosuppressive organ, and that's probably a good thing, right? Because everything we eat enters the portal blood, with rare exceptions, and passes through the liver. So if we had a very invigorated, active immune system in the liver, that would be problematic every time we ingested a foreign antigen. And we see this play out clinically from time to time. Liver transplant patients in general need less immunosuppression than kidney transplant patients, and so on and so forth. But again, tumor cells are diabolic, and they hijack and exploit these mechanisms. So this immunosuppression that we see in the liver at baseline becomes exacerbated and gets worse and shuts down the patient's own immune system and prevents them from responding to checkpoint inhibitors and cell therapy. And there are multiple cell types in the liver that play a role. The most abundant non-parenchymal cell type in the liver are liver sinusoidal endothelial cells, or LSEC. And it's a fascinating cell type because they secrete various mediators and express proteins that actually shut T cells down. These cells are probably the most important part of baseline liver tolerance or immunosuppression, and this gets worse in the setting of cancer. In an early study that we did, we looked at the ability of these LSEC to take up protein antigens, and then we studied whether or not they would actually stimulate T cells, and we compared them to dendritic cells, which are the most potent antigen-presenting cells. We actually found that in vivo, LSEC were better than dendritic cells at taking up antigen. So this is part of that reticuloendothelial system that we learned about in medical school and may still see in the textbooks. These cells take up a lot of the protein that passes through the liver, and they actually present it to T cells. But what happens when they do that? This is a T cell stimulation assay, and the bottom line of what we saw is that when this cell type shows a protein to T cells, the T cells shut down. They don't divide, they become anergic or tolerant, unlike when a dendritic cell does the same, and then the T cells are stimulated. So you have billions of cells in the liver that are taking up protein, and these cells are designed to make T cells quiescent and shut them down. And this gets worse in the setting of cancer. And this is a scanning EM of those cells, and you see these little fenestrae or holes in the cell membrane, which are very classical for LSEC, and these increase the surface area, which is part of why they're so good at taking up antigen. And so then we began looking at liver T cells in particular, and we compared T cells in the liver to the spleen to see how they were different. So again, one thing I'm going to hammer home over and over again today is that immune biology in the liver is unique, and the liver programs immune cells in a very unique way. The good news is that it's reversible, and so you can treat it potentially. And so we looked at liver T cells in vitro, and they make very high levels of IL-4 and IL-10, which are suppressive cytokines. Spleen T cells don't make the same levels of these cytokines. And one of the most interesting experiments that we did is we took liver T cells and put them in the spleen. And when we put them in the spleen, they actually started to divide. And so what that tells us is that, again, this is reversible. So the impact that the liver is having on T cells can be changed. And as we like to say sometimes, it's druggable. So it's very important to understand because that gives us an ability to modify what's happening inside of our patients. And of course, we wanted to learn whether or not this was relevant in patients that we treat and operate on. So when I was a fellow, we did a lot of tissue microarray studies. Where following resection, we used immunohistochemistry to look at T cell infiltrates and immune cell infiltrates in these tumors. And what we found was that when patients had a high number of CD8 T cells, which are the type of T cell that can seek and destroy cancer cells, so-called cytotoxic T cells, patients who had a lot of these in their tumors, like this patient on the left, they lived longer. They were much more likely to be 10-year survivors. The bad news is that fewer than 20% of these patients fell into that category. So what this taught us was that the immune response in the liver is very relevant. It's very important to patients with metastatic or primary liver tumors, but most patients don't mount an effective immune response. So this is where we have to help them do better. And we looked at other markers and CD8 T cell infiltrates. We confirmed the yellow line were patients who had a high number. They lived longer, but again, this is the minority. We also looked at FOXP3 cells, which are regulatory T cells, which are immunosuppressive. Patients who had more of those did much worse. And this was colorectal, very similar finding in neuroendocrine liver mets, a high number of regulatory T cells associated significantly with shorter survival time. Again, so the immune response in the liver is a critical driver of patient outcome, but most patients do not mount effective anti-tumor immunity. And then we also looked at tumor features. So MHC is a protein that tumor cells use to present or show antigen to a T cell. So if tumor cells have MHC molecules, then the T cells can recognize them and kill them. What tumor cells do is called immune evasion. So they lose expression of proteins that allow the T cells to recognize them. So what we see very often in solid tumor biology is that tumors will drop or lose expression of MHC1, and so thereby T cells can no longer recognize them and see those antigens. And so what we found is that in patients that had high levels of MHC1 and a high number of T cells, those are the patients that really live the longest. But again, fewer than 20% of patients fit within this category. So most patients are not mounting effective anti-tumor immunity. And then finally, we also looked at macrophages. CD68 is a marker for a type of macrophage that's very effective in supporting an anti-tumor immune response. Patients that had a high number of these cells, the blue line did better, low number did worse, but again, these are the minority of patients. And the macrophage and monocytic population is very interesting in the liver, and that's where we're going to jump to next. Because this is a very plastic population, which means it's easily influenced by its environment. And the liver is particularly good at reprogramming monocytes and macrophages to become highly suppressive. And they become a cell type called myeloid-derived suppressor cells, or MDSC. And this cell type, we think, is the key culprit and driver of immunosuppression and immunotherapy failure in the liver. And so we'll spend a bit of time on that. So myeloid-derived suppressor cells accumulate within the liver in patients who have primary metastatic tumors. You won't find a lot of these cells in a normal liver. What happens is that when patients develop intrahepatic malignancy, various cytokines, including GM-CSF, are released into the blood, and these cells are mobilized from the bone marrow and other sites, and they accumulate in very large numbers. And these cells are essentially conducting an immunosuppressive orchestra. They influence many, many cell types in the liver. They can shut down T cells, they can shut down B cells, and so on and so forth. And so in essence, we think the master switch, if you will, for immunosuppression lies within this cell type. Because the way we're thinking about this research is we don't want to just acquire this knowledge for its own sake. I mean, that's important, we do. But what we're really after is to look for a target that we can drug or treat to reverse this problem so that patients can respond to immunotherapy. And so all of our myeloid suppressor cell research has focused on defining what those targets may be so that we can reverse immunosuppression and allow these patients to respond to checkpoint inhibitors and cell therapy. And so a few slides from our murine model. What we found very early, and these histograms are looking at levels of myeloid suppressor cells, is that in the setting of tumor, so this is a normal liver, and when you give them mice liver metastases, the number of MDSC in the liver increases dramatically. And this bar graph is showing a suppression assay where we took the cells out of the liver, put them in vitro with CAR T cells, and we showed that the MDSC can shut down CAR T cell function. And we suspect that this is exactly what's happening in our patients clinically, is that B cells are shutting down the T cell ability to respond to the cancer. And so then we asked, well, why is this happening? And so when we looked in the mice, we found that GM-CSF levels were increasing along the exact same time course as myeloid-derived suppressor cells. Now, this is interesting because GM-CSF is something we typically think about as an immunostimulatory cytokine. In fact, we often give it as an adjuvant for vaccines, and it's part of TVEC, which is the oncolytic virus that was approved for melanoma. But immunology and immune biology is very contextual. So what happens in the liver is very different than what happens elsewhere in the body. And within the liver, GM-CSF is one of the most immunosuppressive mediators. It is the key driver of myeloid-derived suppressor cell expansion. And you can see that from this time course. And in this in vitro experiment, we cultured bone marrow cells with GM-CSF or with tumor, and we found that because of the GM-CSF, these cells were converted into MDSC in vitro, which matched what we saw in vivo. So why are these cells so suppressive in the liver? The next thing that we found was that not only does GM-CSF get them to expand and become very numerous and abundant in the liver, GM-CSF is also reprogramming these cells. So remember I mentioned that there's a lot of plasticity in this cell population. They can be modified and reprogrammed genetically and epigenetically. And so these cells are induced to express two very immunosuppressive molecules, IDO, which is an enzyme that catabolizes tryptophan, which is very immunosuppressive, and PD-L1, which if you remember from earlier in the talk, is the ligand for PD-1, that checkpoint molecule. And so now you have the cell type in the liver that's very numerous and that's expressing these two immunosuppressive molecules that are shutting down T cells that the patient may have, and they're shutting down CAR T cells that we may give to the patient, and they're preventing patients from responding to checkpoint inhibitors. And in this bar graph, we're showing that when we looked at levels of PD-L1 and IDO expression, they shot up when we added the tumor cells to the myeloid suppressor cells. But when we blocked GM-CSF or the GM-CSF receptor with a monoclonal antibody, these levels came back down. So this showed us that GM-CSF was really responsible for this immunosuppressive programming of myeloid suppressor cells. And just taking this deeper into the cell until we got to the nucleus, we also saw that STAT3 was being activated or phosphorylated along the same time course or a similar time course as GM-CSF. And so GM-CSF was activating STAT3, and STAT3 was actually binding to the IDO and PD-L1 promoters. This is a CHIP assay, a chromatin immunoprecipitation assay, where you can look at what proteins are binding to specific regions of DNA. And we found that STAT3, when phosphorylated, was actually binding to the promoters of IDO and PD-L1. And so GM-CSF was programming these myeloid-derived suppressor cells to express high levels of these suppressive molecules using this mechanism. And it gets worse because GM-CSF and STAT3 are also making MDSC immune from apoptosis. So we looked at a couple of markers of apoptosis, caspase and BAX, and we found that at baseline, MDSC expressed very little. And then when we blocked STAT3, these apoptotic markers went up. And we looked at BCL2, which is a pro-survival signal. This was very high in MDSC at baseline, but when we blocked STAT3, levels went down. Why does this matter? It's more than just esoteric molecular biology. It matters because these are targets that we can develop drugs for. And that's why we're so interested in understanding this mechanism, because this is something that's specifically happening in the liver in this cell population. So understanding the unique signaling events allows us to develop strategies and drugs and combination therapies that can enable immunotherapy to work. So to summarize what we learned about GM-CSF, the immune effects of GM-CSF are very contextual. What happens in the liver is very different than what happens elsewhere in the body. When you give GM-CSF subcutaneously, it can stimulate your immune system. When you give it into the liver or when it's secreted in the liver by tumor cells, it's highly immunosuppressive. And this is the mechanism that we published. And so overall, the liver tumor microenvironment is driving MDSC expansion and survival. It's driving the abundance also of another cell type called M2 macrophages, which are another immunosuppressive monocytic population, and the expression of these immunosuppressive molecules on these cells. MDSC also suppressed B cells. We also looked at B cells in the liver. We probably don't think about the liver having a lot of B cells. We think of the lymph node and the spleen, but it turns out the liver has a very large number of B cells. 20 to 30% of the leukocytes in the liver are B cells in certain patients. And MDSC can also shut these cells down as well. So again, MDSC are orchestrating this very immunosuppressive environment. That's why we think that master switch may lie within that cell type. And so this is all fascinating when you study it in mice, but we really need to know if this is what's happening in our patients. And so when we do our CAR T studies, and this is incredibly important for any of you that are going to be interested in phase 1 studies or clinical research in general, is the correlative science or the tissue that you can get from the patients, which, Rich, as you pointed out last night, surgeons control. And so we want to be aware of that, that what you learn from these tissue samples is so important. And what we want to do is correlate what we're seeing in our animal models to what's happening in patients. Because if we can't do that, it really doesn't mean a lot, and it's not very valuable in the grand scheme of things. So this is biopsy data from one of our patients who got CAR T infusions in a phase 1 study. And we looked at markers for myeloid suppressor cells. CD14 and CD15 are among the most common markers used in patients. And we looked at phosphorylated STAT3, which again is the key driver of the MDSC immunosuppression story in the liver. And what we found when comparing normal tissue to tumor is that there was an abundance of MDSC in the tumor, and we saw phosphorylated STAT3. And so it was just important for us to confirm that we're seeing something similar in patients to what we saw in our animal model. And the way I think about translational research is it's iterative or it's cyclical, meaning you learn something in an animal model, you develop a clinical trial or a therapeutic, and you learn what you need to learn with patients from a safety standpoint and from a correlative science standpoint. But then often you want to go back to the animal model because you're going to develop new questions, new ideas, and new hypotheses based on what you're seeing in your clinical trials and in your patients. And so when we saw some of that, we went back to the mouse model, and we really wanted to know if this effect of the liver on MDSC is truly unique and is it truly reversible. And so we did a series of experiments where we took bone marrow MDSC and we gave them to mice either via the portal vein, so they ended up in the liver, or via the tail vein, so they ended up in the lung. And these mice rather all had tumors. And what we found is that when we transferred these bone marrow cells into the liver, these black bars, these cells started showing very high levels of STAT3 phosphorylation. But in the lung, that didn't happen. In the lung, it was all driven by STAT5. And in the liver, there was very low STAT5 activation. So it's truly a unique organ-driven programming event. So again, the liver has a very unique effect on the cell type. And to show that it was reversible, we actually took MDSC out of the liver and then gave them to different mice into the lung, and we showed that all of this went back to normal. The STAT3 levels came down, other features of the MDSC changed, so the liver programming effect was completely reversible upon putting these cells in a different environment. Again, why does this matter? Because it tells us it's reversible, it's treatable, it's druggable. And knowing that STAT3 and GM-CSF are mediators of this, we have targets that we can go after. And we also took a broader approach looking at proteomics, just pictorially showing you how different the organs affect these cells. When we transferred bone marrow cells into the lung versus the liver, you can see how different these are in terms of the proteins that are expressed. So just putting these myeloid cells in different organs has such a profound effect on how they're programmed at a genetic level and at a protein level. So that tells us when we think about these patients and there are tumors in the liver and tumors in the lung, we should think about them as different diseases and different organs, because what's driving the biology, what's driving the treatment failure is different at different sites. And so it changes the way we think about malignancy, and I think that's important, particularly for immunotherapy. And so one of the most interesting papers that I've seen recently, this came out in Nature Medicine a couple months ago, they looked at cutaneous melanoma patients who got systemic checkpoint inhibitors, so nivolumab, pembrolizumab, ipilimumab, et cetera. And they looked at patients with liver metastases and those without liver metastases. And what they found is that patients with liver mets did a lot worse. They also found that patients with liver mets had significant correlates or signs of immunosuppression, not only in their livers, but throughout their bodies. These patients with liver mets had higher levels of circulating MDSC, for example. And so what these authors showed with a combination of clinical data and preclinical data is that liver tumors were actually driving systemic immune failure or systemic immunosuppression. So the liver is sort of a hub for resistance to immunotherapy. And so treating tumors within the liver in these patients with novel immunotherapeutic approaches, I think, is going to be so important to get them to respond not only in the liver potentially, but also systemically. And so to summarize what we've hit upon so far, the liver is incredibly immunosuppressive at baseline, and tumors make that worse. Effective immunity to liver tumors is helpful if it happens, but it's very rare. Liver tumors exacerbate immunosuppression in large part by driving this MDSC population, which contributes heavily to immunosuppressive failure. But the good news and silver lining are that this is treatable because it's reversible, and we have targets that we believe that can be exploited to help patients respond to immunotherapy. And so let's shift gears to therapeutic delivery barriers. So as I mentioned earlier, one of the things we overlook quite a bit in oncology is a very simple question. Is the drug that we're giving our patient, either systemically or even regionally, is it getting inside the tumor in sufficient quantities or therapeutic levels? The answer is all too often no. It's just not something we think about or ask very often. And here's a very simple illustration of how I think about this. When you're treating a leukemia patient with CAR T cells, it's simply a matter of the target being hit by the CAR T cell. The tumor cells or malignant cells are circulating in the blood, and when they meet, the CAR T cells can destroy the tumor cell. For malignancy, you have, in the liver, you have a delivery barrier, which has to do with distribution or pharmacokinetics, but also pressure, which I'll mention in a moment. And then you have other problems, immunosuppression, MDSC, cancer-associated fibroblasts, low pH, hypoxia, et cetera. And so again, we have to think about treating liver tumors in a very holistic way. And so what are the physical barriers? So when you think about a solid tumor, it's a very complex biologic system. Most people in this room have actually felt solid tumors. And when you feel a tumor in the pancreas, for example, is it soft or hard? It's usually very hard. And there are reasons for that. And if you think about them at a molecular level, you can understand why delivery can be very challenging. So PDAC, or pancreatic ductal adenocarcinoma, is a very desmoplastic tumor. So there's a lot of abnormal, disorganized collagen deposition. Well, what this does is this can collapse blood vessels and increase intravascular pressure within the tumor and make it very difficult to get drugs inside the center of these tumors. And what would you say about tumor vasculature and endothelium, normal or abnormal? Right? It's very abnormal. It's disorganized, it's leaky, and what happens, fluid escapes from the vascular space into the interstitium, raising interstitial pressure, Starling's forces. And so when you have a drug in the intravascular space, it can't get out. And so drug delivery is compromised significantly. And so developing solutions to these delivery barriers, we think, is also very important to treat patients with liver tumors using immunotherapy, although these problems apply to all therapeutics. And here's just another concept diagram of the challenge within tumors, particularly in the center of tumors. Often when you do an angiogram for a patient with a metastatic or primary liver tumor, you see the periphery of the tumor light up a lot more than the center of the tumor. And this is part of the reason why that happens. So local and regional delivery are gaining significant traction in the field of immunotherapy. And there are several approaches, and I just want to compare delivery approaches so we can get a handle on how to think about it. So traditional oncology therapy is given intravenously or systemically. It's easy, it's cheap, and it's reproducible. But the therapeutic index is low, meaning the ratio of efficacy to safety or adverse events. Delivery is very poor. There are some studies that show that less than 1% of a chemotherapeutic drug that you give systemically gets into a solid tumor. And so that's the challenge with systemic delivery. Intratumoral delivery, so something like direct needle injection, also simple, also low cost, better therapeutic index, but you're often not able to deliver the drug effectively. So if you study drug delivery with a needle, for example, if you use a fluorescent molecule, what you'll find is that the drug is really only going to be found along the needle track. So if you have somebody with a 5-centimeter liver tumor and you stick a needle in the center of it and inject the drug with a syringe, you're not going to get whole tumor coverage. And then many of our patients have multiple lesions throughout the liver, many colorectal patients, HCC patients. You're not going to inject 3, 5, 8, 10 lesions. And so it's just impractical and ultimately ineffective. Regional delivery, and what I'm talking about is hepatic artery infusion for liver tumors, is something that we've been doing for a long time, using the pump and interventional radiology approaches. It's practical, it's well established, you can improve the therapeutic index. There's more cost associated with it, logistical challenges, but ultimately, I would argue this is the best way to get effective drug concentrations into liver tumors while minimizing toxicity. And overcoming the pressure barrier using specialized delivery devices, which is something that we focus on at TriSalus as a company, is incredibly important. Here's a quick summary of all the trials that are open now with local and regional immunotherapy. I'm not going to go through these, but I just wanted to make the point. There's a lot of interest in this now. This is not some fringe esoteric topic. There are a lot of companies and academic medical centers studying regional and local delivery of immunotherapeutics. And so this is something that you're going to be seeing in your patients, I predict, within the next 3 to 5 years. So something to be aware of and pay attention to. And just getting back to the murine model for a moment, we found that when we gave CAR T cells into mice with liver tumors, when you gave them systemically, you would find most of them in the lung and in lymph nodes. And when you gave them regionally, you'd find most of them in the liver. Not a big surprise. And when we gave them regionally, the mice lived longer. So early proof of concept. And this was a follow-up study showing the same thing. When we gave the regional delivery of the CAR T cells, the mice did significantly better than systemic delivery. And here's an example of a mouse treated with regional delivery versus systemic or control. So you're just getting more of your therapeutic into the liver and avoiding systemic exposure. I always tell people in my lab, if you want to convince me of something, don't just repeat the experiment 3 times or 5 times. Do a different experiment and reach the same conclusion in an entirely different way. So that's, to me, what's most convincing. And so we repeated this with a different model using an NK cell, allogeneic cell therapy product in a xenogeneic model. So we used human tumor. And we found also in this model that giving the cells regionally was significantly better than systemic delivery. And this bar graph is just showing the percentage of cells in the liver, and it was significantly and several-fold higher when done regionally. And so the drug that I'm most focused on now and that we're interested in at TriSalus is a TLR9 agonist. Because not only do we have to improve drug delivery, but we have to reverse this immunosuppression problem in the liver. And toll-like receptor agonists, which if you recall is what Dr. Coley was using, even though he didn't know it at the time, are very interesting molecules because they can stimulate the immune system and program it at a very high or broad level. And it turns out that these drugs can also reprogram or eliminate myeloid-derived suppressor cells. Now, you can't give them systemically, because stimulating the immune system in this way broadly throughout the body is too toxic. And they're traditionally given by direct needle injection, but from what I told you, that's not very effective. And so we tested TLR9 agonists in our mouse model regionally and systemically, and regional delivery was significantly more effective. And so just like the CAR T cells, giving the drug regionally, getting the therapeutic level or concentration inside the tumor allows the drug to perform better. And we also found that when we gave the drug regionally, we could reduce MDSC or myeloid suppressor levels significantly compared to systemic infusion. So this is a potential way to reprogram the very suppressive TME within the liver. And ultimately, what we want to do is combine a TLR9 agonist given regionally with checkpoint inhibitor. So going back to the beginning of the talk, the goal of all of this work is to help liver tumor patients respond better to immunotherapy, like checkpoint inhibitors and like cell therapy. And so in this experiment, we combined the TLR9 agonist with an anti-PD-1 antibody, a checkpoint inhibitor, and we found that the mice that got both, the TLR9 was given regionally, the checkpoint was given systemically like we would do in the clinic. These mice did significantly better than getting either drug alone. And so this is what we're actually testing in clinical studies now, is this very same approach. And this is how I think about translational research. Is study something in a murine model or another animal model, and then bring it into the clinic, and then go back again when you need to answer different questions. So to summarize this section, the disease includes biologic delivery barriers and organ-specific immunosuppression. So again, we can't just think about cancer cells and killing cancer cells. We have to think about the tumor microenvironment. We have to think about treating dysfunctional immune systems within particular organs and overcoming these delivery barriers. The one thing I want to emphasize is regional delivery or regional therapeutics, not mutually exclusive from systemic. I think ultimately for some diseases like PDAC, it's going to be a combination of regional immunotherapy with systemic immunotherapy or systemic cytotoxic chemotherapy. But the regional part, I think, is going to be essential, necessary, but not sufficient, if you will. And don't assume the drug is getting there. One of the reasons the drug may not be working is because you're not delivering it effectively. So very important to keep that in mind. And so in this last section, I just want to go through some clinical data. And so the CAR T cells that we studied were going after CEA, which I'm sure all of you know, is expressed throughout the body, but it's expressed at very high levels on colorectal cancer, pancreas cancer, and gastric cancer. And another group had studied this systemically, and what they found is when you gave the cells systemically, patients got severe colitis. So they stopped the study after 3 patients. So just an example of how regional delivery can improve therapeutic index. Another big problem with cell therapy is something called cytokine release syndrome, where you treat patients with a cell therapy product and it starts working a little bit too well, and they get very high levels of cytokines like IL-6, which is, by the way, why COVID patients get very sick, because the immune system is ramped up in a very dysregulated way. And so patients who get CAR T cells systemically often have this problem. Regional delivery is a way to mitigate this. There have actually been a lot of regional cell therapy studies over the years, largely out of Japan, Korea, and China, and some success, but the problem these investigators had is when they were doing these studies, we didn't have effective cell therapy technology. So I think they had the delivery approach right, but they were using very primitive forms of TILs or lymphokine-activated killer cells, and so they didn't see a lot of success. But there's been interest in this for a very long time. And here's a quick schema for the studies that we did, where we would give patients infusions of CAR T cells into the hepatic artery, so outpatient interventional radiology procedure. We'd give a very high number of cells, up to 10 billion cells, directly into the hepatic artery. We treated over 20 patients. Here's an example of a good partial response in one of our patients with metastatic colorectal. And he survived 54 months, and so he had a partial response on PET scan in the liver. And this area here in segment 8, which was residual disease, I took him to the OR and I did a microwave ablation of that. And before I did that, I took out a fairly big piece of the tumor to study it on the flow cytometry. And we found the CAR T cells 3 months later after giving them into the hepatic artery. So just an example of effective delivery using this approach. This was very well tolerated. So we were giving huge numbers of these cells, 10 billion cells directly into the hepatic artery, and liver function would spike for 48 or 72 hours, but it would come back down. There were no severe liver or biliary toxicity events. And one of the things that's very important in immunotherapy, and this is a key take-home for the trainees, is that measuring response can be very, very difficult. Something called pseudoprogression is something we have a lot of trouble with. And what happens is when patients get immunotherapy, like CAR T cells or checkpoint, the tumors can initially swell or get bigger. And it can take time for that to evolve into an actual radiographic response. And so that's why biopsies are so important. And we showed that 4 of the patients had an increase in fibrosis, 3 had an increase in necrosis. But again, tissue in these studies is so important, and surgeons often control the tissue. So it's a great way for surgeons to get involved in immunotherapy research is through the tissue avenue by providing the tissue and collaborating on tissue-based studies. And it's so important with immunotherapy because radiographic responses can be very difficult to read. And so other correlates of response that we looked at were interferon gamma levels. The patients that had the best responses to the CAR T therapy had early spikes in serum interferon gamma. So we're always looking for cheap and easy correlates of response. And here's an example of some radiographic responses in one of our studies. You can see that most of the patients by the end of the study either had stable disease or decrease in size. And so that's how regional delivery can help cell therapy for liver tumors. But then again, coming back to this pressure problem, how can we improve it? One of the things that we noted when we did our initial studies, giving CAR T cells directly into the hepatic artery, is that when we did biopsies pre and post treatment, we were seeing virtually no CAR T cells in the tumors. And this was surprising, it was frustrating, and we think the reason was intratumoral pressure. So we did another study that was actually done in collaboration with this very medical center. The funding actually came through the state of Colorado. Dr. Schulich was a co-investigator on the study. And what we found, comparing it to a previous study, is that the level of CAR T cell delivery into the tumor alone or into tumor plus normal liver improved more than 5-fold. So same delivery approach, we just use a different device. And this device has a special valve that opens and closes in sync with the patient's heart. It essentially augments delivery pressure, improves flow to the tumor, and this technology was able to improve delivery of CAR T cells more than fivefold. And this, on the lower left, what you're seeing is peripheral blood data looking at PCR, and we would find the CAR T cells only transiently for about a week in the blood. So we were able to get them into the liver, but avoid systemic exposure. Very, very important, because remember, this cell type was very toxic when given systemically. And so here's the paper that we published, and you can see the authors from your medical center. And this was a case report on one of the patients from that study with stage 4 pancreas, liver mets, who actually had a complete response on PET scan. So one patient, can't make too much out of one patient ever, but in that disease, when you see something like this, it does get your attention. And so here's some imaging from the patient, showing from baseline to post-treatment the complete PET response, loss of metabolic activity, and on cross-sectional imaging, partial response, but probably very little, if any, viable tumor remaining in that area. Here's a biopsy H&E section post-treatment showing near complete fibrosis, and here are his tumor markers post-treatment. This is a patient who failed FOLFIRINOX, and this response was durable for 13 months. And again, we also want to look at tissue. Again, surgeons control tissue, and it's a great way to learn as much as possible. And we always want to learn, again, if what we're seeing in our animal models is actually real. Is it happening in our patients, or is it just interesting trivia that we're filing away? And so looking at these immunofluorescence images, what we confirmed is that at baseline, obviously there are no CAR T cells in the patient. Those are the red dots. A few T cells, the green dots. But post-treatment, a very high number of CAR T cells with overlap of green and red. Green is CD3, red is the CAR protein. And then on the bottom here, you're looking at CEA. There's a loss of CEA because we've killed tumor cells. But then we also looked at some of these molecules that we studied in the mirroring model, and what we found is that PD-L1 and IDO and GM-CSF all went down over time. So as this patient had a favorable immune response, somehow the immune microenvironment, probably because the CAR T cell was very active and secreting interferon gamma, et cetera, the immune microenvironment was converted into something more favorable, losing IDO, losing PD-L1, losing MDSC. So this was great for this patient, but this doesn't happen in most patients who get the CAR T cells. That's why we think we need to give another drug along with it, like a TLR9 agonist, to reprogram that TME and get rid of the myeloid suppressor cells. And so I'll just point out once again how response assessment can be so difficult in these patients. And so this is a baseline PET on one of the patients that we treated. Short-term imaging, the patient's progressing. It got hotter on PET, it got bigger on MRI, and we just waited a little bit longer. And it ultimately evolved into a partial response. So that's a critical take-home message. When you're seeing patients with immunotherapy, if they're imaged at 6 weeks or 8 weeks, which is really quick, you need to wait another 2 or 3 months or longer to see how the response is actually going to evolve. So this is something that's relevant today in 2021 as you're caring for cancer patients, because you're going to have patients on checkpoint inhibitors and you're going to see imaging studies, and you need to be aware that short-term imaging may be what we call pseudo-progression, and you have to wait longer to see if it's going to be an actual response. And so coming full circle, what we're doing today is we're studying a TLR9 agonist using that delivery technology that I mentioned to see if we can enable patients to respond better to checkpoint inhibitors. And what we're trying to do is use the TLR9 agonist, enable it to work by giving it regionally with that high pressure technology to eliminate MDSC in the liver and give patients a checkpoint inhibitor. So we're studying this in uveal melanoma, liver metastases, which is a study that is going to be open here. Then we're going to study it in HCC and intrahepatic cholangio, which we'd also like to open here. And there will be other studies as well. This is going to be a platform that we think can be effective across many indications, because what we're really going after is treating the dysfunctional immune system that we think is unique and very specific in the liver. And so we think that it can be effective across multiple cancer types. And so last summary slide, hepatic artery infusion we think is promising to enable cell therapy in liver tumors. We think we have to overcome the pressure barrier. We're very convinced that we have to reverse the immunosuppressive problem in the liver, which is very specific to that organ. And we have to be innovative and creative with response assessments. So immune dysfunction in the liver limits efficacy of immunotherapy. Delivery barriers are critical. The liver programs MDSC in a very unique way, and we have to treat that. And success will require treatment of the entire disease in the liver, not just the tumor, but also biologic delivery barriers and immunosuppression. So that's it. I want to thank you for your attention. It's great to see some of you in person. For those that are watching on Zoom, I'm glad you're able to join as well. Happy to take questions.
We have time for one quick question. I'm going to look to my immunotherapy folks. And then I want to remind everyone we have a case conference at 8:30 in Freeman, 6101, 6th floor of our AO1 building. I encourage all of you who want to interact with Dr. Katz some more and listen to some interesting cases to come. One quick question, Dr. McCarter.
Dr. Katz, that was really a phenomenal summary of the incremental benefits of all these steps. You pointed out that each one of these little things might not a whole lot, but when you sum it all up, you get to something that you presented here. So, you know, at the end of the day, the tumor resistance is multifactorial, as you pointed out. You targeted a couple areas, MDSCs, access. What other things do you think we need to approach to improve this immune response?
So I think first and foremost, we want to think about it organ by organ. I think that's important. Within the liver, it is complex. We like targeting MDSC because we think they're very high up in the pathway and they're influencing so many other cell types. And we like TLR agonists because they also impact multiple cell types. So I think just going after STAT3, for example, wouldn't work as well as using a TLR9 agonist because TLR9 agonists will hit MDSC, B cells, dendritic cells. We have to use approaches that I think reprogram the TME at a very broad level, to your point, and not try to be too fine with our approaches. And so again, we're looking for more of a master switch that can have a very broad influence on the dysfunctional immune system in the liver. And we think this approach has the potential to do that. We'll see what we learn in the phase 1 studies.
So again, I want to congratulate you. You know, I obviously interact with a lot of surgical oncologists and surgeon scientists. Yeah. You are at the top, the pinnacle in terms of examples. And I encourage our trainees and young faculty who want to learn a little bit more about this pathway to talk to Dr. Katz. We'll make his email and phone number available. No one leaves Colorado without a little goodie bag. So you've got a backpack, the history of our department, a cap, our tie that you were commenting on, and then something's also on the way by mail to you.
Thank you very much.
Congratulations. Well done.
Thanks, Rich.
Yeah.